Bonjour, bonjour, mes amis. It is delightful to have you here with us this evening. And I know you're going to be even more delighted because we have our CEO here with us this evening. Hello, Miss Tracy Wood. How are you doing today?
I'm well. How are you?
I'm well, thank you. And I'm looking forward to this conversation we're about to have because I know pharmacogenomic testing is something near and dear to your heart. And I know a huge
It
passion
is.
project that you've brought forward to the DNA company.
It is.
Yes.
And hi, Jess. I see Jessica. Yeah, it is.
Yeah.
A lot of people don't understand really the history of pharmacogenomics, right?
Mhm.
And it's really it's like this fascinating intersection between genetics and pharmacology,
Yeah.
right? And it
Mhm.
really has evolved significantly as really genetics has evolved into genomics and functional genomics, right?
Yeah. Yeah.
Um, and it started back in the 1930s. So
Mm.
in the 1930s, physicians noticed that certain patients responded to medications better than others, right?
Mhm.
And
Mhm.
and while they were trying to kind of prove what the genesis of that was, they still had a long way to go. And so somewhere like in the late 50s, early 60s, there was a German geneticist, and he kind of coined the phrase
Mm.
pharmacogenetics. And it was defined as the study of how inherited genetic differences affect individual responses to drugs. That was the actual definition of it.
Mhm.
And they started researching the difference in specific gene polymorphism. I can never say that word. Polymorphisms,
I'm so proud you're part of the club. Too many
right?
syllables. It's fine. It doesn't count.
It's just a dumb word.
I
Okay, it's
agree.
just a dumb word. I think we should come up with something else. Anyway, but what they tried to do is they're trying to literally identify this specific
Mhm.
genetic variations, right? And then, you go all the way through to the Human Genome Project, right? And we start going from studying genetics into genomics and functional genomics, which is where, we as the DNA company really excelled comparatively speaking to the other folks in our space. And it allowed us to see that single gene drug interactions were indeed possible, right?
Mhm.
And so that's kind of where we got involved. The FDA has started regulating the testing. Certain people were doing testing. There was Medicare, Medicaid being billed thousands and thousands of dollars for this stuff, and the FDA pumped the brakes and said, "You know what? Everybody, just hold up." In 2018, Medicare CMS pulled approval for reimbursement for the test. So
Mhm.
there's been a lot of battling back and forth. Long and the short of it, just 2 years ago, we started getting it approved for some people with specific insurances. And a lot of people can actually get reimbursements, whereas before they could not. So when I joined the team and started working with Kashif, this was a passion project to me, right?
Yeah.
My sister died of a medical mistake, right? It
Yeah.
was a serious drug interaction. And while pharmacogenomics testing wasn't where it is today and it wouldn't have changed anything, it really is what drew me into
Yeah.
the health and wellness space, right?
Yeah.
So, she's been gone since 2007. We finally get pharmacogenetic testing in 2018. Medicare, Medicaid pulls it on and off twice until we get into 2022. And now we've got it to a point where pharmacogenomics testing is more affordable, even if it's not covered by your plan. And that was really the goal for Kashif and I, in my opinion.
Yeah. Yeah.
Um, but one of the things that drove that, as you know, is the medical errors that are
Yeah.
happening in the United States, right?
Mhm.
So
Mhm.
when you look at right now, medical errors cause between a quarter of a million and 400,000 deaths a year. Now, think about that. What if you or your spouse or one of your children are one of these medical mistakes? There is a statistic right now through the Department of Health and Human Services that says for every patient, now some of you have been to an ER, I can guarantee it. For every patient admitted into an ER in the United States on the daily, Per bed, one medical mistake has been made.
Yeah. It's a
Okay, so that means
lot.
everybody. So if you've got 50 beds in that ER, there's 50 mistakes made
It's a
until you
lot.
bring new people in.
Yeah.
And that number is 1.3 million. 1.3 million. So out of that, we've got 250,000 people that are dying. And it is because of things like this. The third
Yeah.
leading cause within those causes, right? One of them, of course, diagnostic errors, surgical errors. You can't minimize that. But the third one is medication.
Yeah.
That's the third one. That's a big
That's
number.
crazy.
Yeah.
That is
Yeah.
crazy. Yeah. Yeah. And there's
And it happens every day.
yeah. Yeah. And to a large extent it can be avoided. We're not talking like emergency situations where there's blood flying everywhere
No.
and it's a spit of the moment decision. We're
No.
talking an admission where there is time and space to consider different variables, and either the
Right.
wrong variables were considered or they were not considered at all.
Right.
And
Well,
that
look at
led
what
to the
happened in
death.
my case.
Yeah. Yeah.
So in the month of April, I had to have a fairly major surgery.
Yeah.
There was a whole lot going on.
Just a
And
little.
I had I had my PGX. I was 2 weeks away from being dead. I think that that's a great statistic that I can actually throw out there now because that's what they told me. I had 2 weeks, and look at me. I feel like $1,000,000. Okay, so I had my PGX done before my surgery. Now I had surgery at a major university hospital.
Yeah.
This was not a little tiny hospital with limited resources. This was massive size hospital, lots of resources. I had
Yeah.
3 surgeons. I had 14 people on the surgical team. I had 19 nurses. That was my team throughout that
Mhm.
throughout that process. So I had my PGX. We put the information in on my PGX, and the information was that I'm allergic to codeine,
Mm.
right? One of the common ones. I never knew I was
Mhm.
allergic to codeine. So it was put in there. Now I'm not a great patient, and I'm going to own
You?
that. Me.
Shocking. Audience, her saying it, she's not a great patient is being very generous. Continue.
I'm not a great patient. So the morning after this, I think it was what, 6, 7 hours, something like that. That night they were giving me Dilaudid. And for anyone that's ever had Dilaudid injected into an IV, that's a tough one.
Mm.
I was hallucinating on that. Um, and I didn't want it anymore. And I wanted to get up and I wanted to be able to ambulate. And they said, absolutely not. I said, get a walker, we're rolling. And I did get up and start moving. So I got to come off of that
Yeah.
drug by the Thursday because my surgery was on the Wednesday. I came off of it on the Thursday. And they said, but you have to have something for pain because I had 9 incisions in my body, right?
Mm.
And I said, I don't want anything for pain. I'm not doing it. And they said, well, we're just going to give you oxycodone. And I went, something doesn't sound right about that. Now, fortunately for me, I had a friend there that was a concierge doctor. And she said, pump the brakes. Here's her pharmacogenomics report. You guys have this. It's in your EMR. And
Mhm.
if you give this to her, you are going to kill her.
Mhm.
And of course, everybody went, whoa, that we didn't know. And she's like, go into your EMR. So your EMR is really another one of those great tools that was
Yeah.
deployed in order to reduce some of these mistakes, right?
Yeah.
And
Yeah.
so that's what they did. Every 4 hours, Dr. Kosterman, every 4 hours, somebody new came in to hand me oxycodone. And had I have been still on the Dilaudid, I'd have been
Mm.
loaded and I would have been like, back it up with a Bloody Mary and we got ourselves a date, right?
Yeah, of course. Of course.
Right. But fortunately, I was not. Fortunately,
Yeah.
I was paying attention and I did have a concierge doc with me and she refused it every single time. They came in the middle of the night and handed me things, right? Because this is what a hospital does. They only have so many
Yeah.
resources, right? So I'm certainly not bashing the hospital, but what I am
Mm.
saying is if you do not, one, test and know,
Yeah.
and two, advocate all the way,
Yeah.
you could have yourself a problem.
Yeah. Yeah.
And that's what I did.
It it like as a bystander to all of this, I think it shocks me that there wasn't more care with we have this wealth of pharmacogenomics, let's make use of it.
Right.
And I stand back and I kind of see two variables as to what might have prevented that outside of just simply hospital overwhelm, et cetera. I see the history that you just detailed, right? We've had access to this for just under a decade, but
Right.
because the beginning of this was a little bit fraught with companies charging Medicare, Medicaid too much, it got a bad rap, right? For
It
better or
totally did.
worse, that's a
Yeah.
reality. And so I can appreciate there's probably doctors, they didn't really look into it, and all they heard was, this is a fraud, this is a scam. So I can
Right.
appreciate there being an elk of
1000%.
doctors who's like, cool, not touching it.
Yeah.
But now that we're coming back and being like, it actually wasn't the science, it wasn't the medicine, this is valid, it's more the way it was initially regulated or lack thereof.
Mhm.
There's nothing wrong with the science. I guess it shocks me that a hospital system as advanced as what you were talking about hasn't made space for this and treat it with more reverence. Because
Well,
it's a
and if
piece of
you think,
paper saying that this is going
right,
to hurt.
but if you think about it, Doc, hospitalization, here's the impact. 1 in 10 experience harm during hospitalization, and at least half of those are preventable,
Yeah.
which generally links back into medication. So
Yeah.
you've got to know what your functional genomics will process or won't process, right? And a
Yeah.
lot of the medications that they're testing for in these tests are used for pain and anesthesia and things like that. So it really is important for people to have that information. But like you said, when it came to the money, it became such a hassle, right?
Hmm.
And it was cost prohibitive for a lot of people, right?
And I would also offer because I want to segue into what we're doing to shift and support this. It's
Yeah,
also a lot for both patient and doctor alike to read through these really dense, heavy information reports and make
right,
use of them, especially in an emergent situation. If you're going
right,
to the ER, the doctor doesn't have time to sift through 100 pages. So
right.
so
But
how
that's why
can
we
we
designed our report the way we did, Doc.
Yeah. Yeah.
That
So
was a big
so
deal
talk
for me.
about that. Talk no,
Yeah,
but talk about this because this is a game changer. This is really important for people to hear and understand.
yeah, no, totally. This is true. So what she's talking about is the report's like, I don't know, 40 pages or something
And
ridiculous.
and she's dense. It's a lot of material in there. It's
Yeah,
intimidating.
there's a shit ton of information in there. So what we did was we said, listen, we need to have an app for our community to be able to better action their functional genes anyway,
Yeah.
right? We wanted people to be able to read their 360 report. We wanted people to be able to utilize that to improve their longevity, to improve their quality of life. All of those things were very important. So that's why I had the app commissioned after I took over as CEO. But the second thing was to put PGX into the app. So we've done that. We've done that first step. So now you get that full 40-page report and it's color coded. So
Yeah.
when you get to each category of drug, your doctor can go, anesthesias, holy crap, they can't have this. Holy crap, they can't have that. And that was really important. We are improving upon the app because I want to be able to have it be part of like your ICE record in your phone. Let's face it,
Hmm.
none of us are ever far from these giant bars of soap, right? We have them with us everywhere we go. I drive
Electronic
to break
leashes.
mine, right? Um, but we're never far from them. So if we've
Hmm.
got an ICE record with our health information in there and our medical information in there,
Yeah.
just dropping PGX in there is not that much of a stretch. So that is something that we are working on actively. And it
Yeah.
was important to me because
Yeah.
the truth is my sister is gone, right?
Yeah.
And there's nothing anyone can do to bring her back. They literally could have killed me 3 months ago. And it wouldn't have been intentional. There's no malice behind it. Doctors don't harm people uh, on purpose, and hospitals don't give people medication to just mess with them. But when you
Hmm.
look at and I don't call them side effects. When you look at the app is free. Whoever just asked that question, when you look at the list of side effects, those aren't side effects, doc. Those are direct effects from the medication.
Hmm.
And
Hmm.
what we've done is we say you could have, vomiting, diarrhea, your head could be spinning, you could be vomiting into a bathtub. I mean, there's so many things that we put in these lists,
Mhm.
right?
Mhm.
Those are all a direct effect based on the genes of the person in the study.
Mhm.
Why are we not saying that? Now, we say that on a warfarin. Warfarin has a pharmacogenomics label. Did you know that?
Yes.
Right. So they have that specifically, and they say this gene, if you have this, you can have that. If we already know all of this stuff about
Mhm.
these drugs, why aren't we just throwing it on the labels? Right?
Yeah.
I mean, you've seen the list of things you get from the pharmacy. Let's throw it on the labels.
Yeah.
Let's
Yeah.
make it so that people can do the research, right? If we are empowered
Mhm.
as a patient, if we can advocate for ourselves as a patient,
Yeah.
one, we might be a better patient. I will never be a good patient, but some people might be a better patient. But two, we don't feel like we're out of control when we're laying in a hospital bed and we don't know what's happening,
Yeah. Yeah.
right?
Yeah.
So I think more information, I think it's important. So
Yeah.
that's why the app is so important to me. It's also why I reduced the price of the test by $200,
Yeah.
um, because this is about a give back to me, right? This is an
Yeah.
important tool for every single person on here to have.
Yeah. And I'd like to highlight another use case of PGX because I think it's really important to avoid those direct effects or at least the unintended effects, right? So
Sure.
we know we want a medication to do something and it may do all this other set of stuff in certain people with certain genes, right? And so
Right.
avoiding those extra effects is really important. I would offer towards compliance, right? Because if we find the right medication with the least amount of extra effects, then there's going to be more compliance on that medication. But I think another part of the conversation, which is really important, is why are you taking the medication and do your genes support that? Why? So, for example, if you're taking something that's supposed to lower blood pressure, based on your genes, certain agents that you take to lower blood pressure, it may or may not have that impact. So, independent of all those extra nasty effects that you don't want, we want to know that the medication's actually working for you. And that's part of what PGX does. It's able to go in and say, based on this gene profile, we expect this medication to work really well at the standard dose. Or maybe you need a higher dose because you metabolize it so quickly, you actually need more to get that effect. Or maybe you metabolize it really slow, and so you actually need half the usual dose. So don't overdo it. And I
Right.
think it's what you've detailed in regards to avoiding all of the horrible is really important, especially in those emergent situations. But I also go back to the date of the day. Why on earth are we taking that medication? And how do we ensure it's actually doing what we want it to do? And that's a big, big takeaway, especially for the GPs and other prescribing providers that are leveraging this.
Yeah, absolutely.
Yeah.
So I am very passionate about it. And as you know, I have a conflicting meeting in 7 minutes.
Hmm.
I am passionate about it. I have not only taken $200 off the retail price, but I've given another code for these guys to drop into the chat window for you to get
Yeah.
another 15% off. I have my PGX in my app. Okay, my
Hmm.
PGX is, if I ever have to go to a hospital, I can literally share that information
Yeah.
in real time with the practitioner team. Doctors don't want to hurt you. They
No.
don't want to do anything bad. Nurses don't want to make mistakes. Nobody wants to see you, tapping out, right?
No.
Nobody wants to see that. But we do have a certain amount of agency in this as individuals. We now know this tool is available. We now
Hmm.
know this tool is being widely used globally. We now know that this tool is 99.98% accurate. And we now know that this tool can reduce the 250,000 to 400,000 people that are dying
Hmm.
every single year because of mistakes. We now know that that can all happen. So, what we do
Yeah.
with that information as consumers and as patients, that lands on us.
Yeah.
So, if you don't have the app already, please get the app. If you've not done your pharmaco, I encourage you to do it because at some point, God forbid, at some point,
Hmm.
you're going to end up in an ER. And what if, when they are well intended and trying to help you, they drop something in your IV that you can't come back from.
Yeah.
I don't want that for anyone in my community. That matters to me. So that's my story, and I'm sticking to it. I got to go. Thank
Au
you,
revoir,
everybody.
Medel. Merci.
Bye. Have a good night.
Bye. All right, audience. So it's just me now. There'll be a little bit less swearing, but what I want to do is I want to go through PGX. I really want to talk about. I want to contextualize a little bit more the hidden risk of medication, and then I want to show you a few examples. I want to make sure we're contextualizing what exactly the information that you'll be getting when you run your PGX is. And if anyone has any questions, don't hesitate to toss them into the Q&A section. We will absolutely um, ensure that they are answered. And Pamela is asking for the code that will give that discount. Vanny or Katie, do you mind just dropping that into the chat? And then I will announce it as well live for the audience. I want to make sure I'm spelling it correctly. Um, while Vanny and Katie are drawing that up for me, I'm going to jump into the poll questions so that we can really ensure we're speaking to what you want to know tonight. Vanny or Katie, could you toss up the poll questions? Mhm. Thank you. And for everyone's awareness, that 15% off the PGX, the code is Save a Life, all one word, no spaces. And you want to capitalize each of those three words. So it's a capital S, safe, capital and then capital L, life. And then that is also in the chat. So you can just copy and paste it if you want. The first question we've asked here through our poll is have you ever experienced side effects or as Tracy beautifully put, intended effects? And unfortunately, 70% of the audience has experienced them. A blessed 14 is saying no. Um, the next question we asked is, has your doctor ever discussed genetic testing with you to guide medication choices? Audience, this makes me sad. Only 90%, which, given the history of it, I can appreciate that. And also the learning curve. It doesn't justify it on the doctor's part, just contextualizes it. And so this really, to me, says if you want to be using this, unfortunately, right now, it's an element of advocacy. You have to be bringing this forward. This isn't going to come forward to you from your doctor. And so, hear that also when you think of those that you love and discussing this with them, really talking about this isn't something your doctor is going to present. This is something you're going to have to champion. The next question we asked is, do you know if your body's a slow or fast metabolizer? So I talked about that as how that can influence how a medication might work in you. Some people are saying just simply based on body experiences or genetic testing, yes, 30%, but a majority of our audience, 65%, is saying nope. And then 6%, I love this honest 6%, is saying, I don't even know what you're talking about. And so that's what the test is to be for. You don't need to know what I'm talking about per se. The other question we're asking our audience is, how many medications are you on? 50% of our audience is on 1 to 2, which again is a bit concerning given you don't have this pharmacogenomic advice, nor has your doctor even talked to you about its possibilities. So we'll make sure you leave with an understanding this evening of what you can be getting so that you can bring this forward to your doctor. And then beautifully, about 60% of the audience is change ready insofar as they want to be leveraging this. So again, audience, um, to unfortunately lay the case for it, when we look at statistics, when we look at the need for this, when we look at admissions to the hospital, so this is not accidents once we're in the hospital, but admissions to the hospital, depending on where you are, it can be about 6 to 12% of those, so up to 1 in 10 is a direct result of bad medication prescription, meaning you start taking a medication, you develop an adverse reaction that is so worrisome you have to go to the hospital and be admitted. 1 in 10. Again, this speaks to a large need for better understanding of how we prescribe. Tracy beautifully and unfortunately talked about this is one of the third leading causes of medical death, of death in the US. For those that cares about dollars and cents, about $136 billion per year of avoidable medical costs. That's specific to the US. Okay. And as a doctor, one of the things that I really care about is compliance. So if you're prescribed a medication, about 50% of people say they're either not sticking to it because of adverse reactions or it just simply not working, which is an incredible number to me. One and two, to an extent, does not start or does not stay on a medication because of something, at least a genetic test, could better inform and reduce that number. So, the why behind that, the why behind all of this, right? We know that I can give a medication to myself, to you, to your neighbor, and you'll get different responses to it. The why of that is we all metabolize drugs really differently. By and large, that's a liver issue. And within the liver, we have a lot of enzymes that the body will curate and say, hey, you work fast, you work slow. Drug companies rely on a lot of livers and the enzymes to either turn on medications, to change medications. So be mindful, audience, that when you take a drug, rarely, very rarely, is it something that will just directly go into the body and act as is. Most of the time, they're developed to react with something in the liver and then they become really potent within the body. Not all, but a good chunk. And this really speaks to why testing is important, because we can test how that liver functions and therefore, or sorry, how that enzyme in the liver is going to function and therefore how that's going to influence the receipt within your body. Okay. Um, so again, pharmacogenomics, it's the study of genes and how your genes are going to interact. It's a really easy test. You take a little cheek swab, that will take cells. Those cells, we extract the DNA information from it, and then we compare it to what we know about different genes and um, different results. Who can benefit from this? Um, I would offer everyone simply know getting your genes will tell us how does that interact with different medications. So, what type of medications do PGX reports cover? There's a lot of study and effort within mental health drugs. So, this can be SSRIs, SNRIs, antipsychotics, and mood stabilizers. For anyone who has been prescribed an antidepressant or any of the more advanced classes of those drugs, knows how difficult it is to, first of all, ask for them, but then also to have to wait for that to have an impact. So, having a pharmacogenomic report sometimes can cut down that time between what is the right prescription and actually feeling the impact of that prescription. And I would go a step further again, more towards some of the psychiatric conditions. Um, it's really difficult to prescribe for this. And we know how horrible adverse reactions can be: weight gain, not feeling great, etc., nausea. And so being able again to prescribe with more precision enables better care, because you're not playing a little bit of a guessing game as to, we hope this agent will work, but we don't know how your body's going to respond to it. Audience, I need you to hear how important that is. When you go to the doctor, apart from not wanting to be hurt or harmed by the drug, we need to know how quickly it's going to act, because that really influences what agent we pick and ensuring you get on the right prescription the first time, as opposed to having to try three or four. So I would offer, in particular for mental health, I think this is really important. We also will, PGX reports will also cover a lot of cardiovascular drugs. So antihypertensives, a lot of anticoagulants, a lot of cholesterol lowering medications as well, right? We've all heard those horror stories about statins. I took a statin and a month later I felt horrible. This sort of thing will help guide that level of prescription. Tracy touched a lot on pain management. So this, our reporting will cover opioids and NSAIDs and a few other agents that are used for both pain as well as analgesics. Sorry, not analgesics, anesthetics. So close, too many syllables. The report will also go through different GI medications. So this can be PPIs, a lot of Americans are on PPIs, as well as some anti-nausea meds. It will go through a few neurologic agents. So think along classes of stimulants for ADHD or other mood meds, some of the ones that I discussed in the mental health. And then lastly, it does go through several oncologic or cancer chemotherapy drugs, to the end of figuring out what might be appropriate. I think this is really important, especially when we think through breast cancer, because there's been a lot of really beautiful research as to what drug agents, what chemotherapies, what preventative agents work well, but compliance tends to be an issue. And so PGX can really offer insight into that. So, audience, I want to go through two real life examples. So, I'm going to go through the drug, I'm going to talk through what the testing can actually offer, and then I'm going to give you a little bit of a snippet of the report. Um, and I want you to be mindful that it's not your job per se to understand this report. Your job more is to ensure your provider has it, as well as your job is to have that app so you have that quick access to the information should you need it in an emergent situation, or if you're going to your doctor and you can quickly look something up and be like, hey, doctor, look at this. All right. So the first class of medication, and I would imagine many people, Tracy touched on this, many people have heard of this, is going to be codeine. So codeine is something that is prescribed commonly after surgery or a trauma of some sort where there's a lot of pain. All right. And codeine, again, we talked about a lot of drugs can be activated by the liver. Okay, so codeine, one of the enzymes within the liver that acts on it is CYP2D6 or 2 Daniel 6. And we know based on different genetic presentations of this gene, of this enzyme, some people may be really poor metabolizers. This means when they take codeine, they actually get less conversion of codeine into morphine, which is that pain reducer. Okay. So this means you're not going to be getting the impact. You're going to try and dose more, or you're just simply going to be reaching for something else. So, knowing this, that you are a poor converter, therefore you're not getting that impact, is really, really important because it either means you're going to pick a different class or you might, with your doctor, adjust how much exactly you're going to be taking. And again, all of these medication adjustments need to be done with a doctor because pharmacogenomics is not the only consideration, but it's a really important one. You're also going to get some people out there that are rapid metabolizers. These are people at great risk for overdose, okay? Because they're going to very quickly convert it. They're going to get that burst of pain, but you have to think about how you clear that drug out. Okay, so both of these categories, kind of the two ends of the extreme, paint really different pictures. One is that risk of great pain relief, but not necessarily long standing, as well as great risk of overdose. And then the other one is a class that isn't necessarily going to feel this. And again, that could indirectly lead to overdosing because you're going to be taking more, not necessarily getting the impact. And so, knowing where you sit on this spectrum for this pain agent is important. It guides, do you take it? Do you consider something else? Or do you adjust how much you're taking? Audience, if the gods are with us, I'm going to share my screen. And on this shared screen will be a snippet from the report. So cross your fingers for me because if you know me, we know that tech is not my strong suit. So just give me 1 second, audience. Um, it's going to work out so well. Okay. All right. I believe this is what we want to share. Oh, so close. That's what we're doing next. Give me 1 second, audience. We're so close. I promise this is going to be great. Um, okay. Audience. I'm really trying, I promise. Here we go. Okay. There we go. All right. So, audience, when you get your report, and again, remember, I'm simply showing this so you understand the type of information you're getting, what you'll see in your report. You do not need to understand this. This goes to your doctor. So for this person, codeine, they're flagged as an intermediate metabolizer. And so it means they're going to get a reduced amount of morphine formed when they take in that drug and when the liver converts it. Okay. And so this is a little bit specific in the sense of, you can use, your doctor can prescribe based on label, but should be age and weight specific dosing. And if there is not a response, again, because you're not converting strongly or well, you can consider, and they give a very specific suggestion of a different opioid that would be more responsive within this person's system. So, the neat thing here, audience, is not only does it tell you how you are metabolizing, it does give options of here's what you can consider if it's not working out so well. So, again, audience, not something for you to understand, but something that can be brought to your doctor so that before needing that agent or in the moment, heaven forbid, it can be adjusted and properly supported for you. Okay. The next example that I want to be offering here is going to be looking at, and I'm probably not going to say this correctly, um, clopidogrel. I'm going to say the branded name because that's just a lot easier. It's Plavix. So this is something that is commonly prescribed, and unfortunately, after heart attacks or if a stent is put in, it's to prevent blood clots. Okay, so it's part of that standard medication regime. And again, this is something that, for better or worse, when you have a heart attack or a stent goes in, there is a list of medications that the doctor will automatically prescribe. And unless you can cite an allergy, unless you can cite a gene, or unless you can cite something very specific, that is the drug routine that you will be put on. It is not unfortunately personalized, but it is something that is well tested. And so we know that just because it's well tested within the masses doesn't mean it's going to be well tested within your body. This is where PGX can come in. It can really educate how is your body going to be responding to this Plavix. Okay. And so Plavix, this is considered a prodrug. It's a fancy way of saying once it hits the liver, it actually has to be activated. So the raw form of the drug, unprocessed, kind of doesn't do much for you. It needs to go into the liver, and it's using an enzyme called CYP2C19 to Charlie 19 to be activated. And while this depends on your population, about 30% of people carry a variant that makes this ineffective, meaning when you take this drug, it actually doesn't do that anti blood clot that you want it to be doing. And a consequence to that, it can raise your risk for cardiovascular event. So again, very unintended facts, kind of two birds, one stone, unfortunately, insofar as it doesn't do what you want it to do, and then has a really grave side effect profile that can include a cardiovascular event. And so this is where getting your PGX can become really important. You understand where you sit on that spectrum. Are you part of that? Again, depending on a few demographics like male, female, race, are you part of that 30% that this is not going to be effective treatment for? And unfortunately, we know how common heart attacks are. And therefore, we know this is going to be a commonly prescribed regime. You want to know in advance of that, is this something that's going to be effective? Audience, assuming the blessing of the gods, I'm going to try and share my screen. I'll show you what you should be seeing. Um, I believe this is it. Yes. Oh, first time audience. Someone should send me flowers for that. All right. So with this, for this person here, we're seeing it twice because there's two snips. So again, audience, remember, a gene is kind of like a book. And within a book, there's a bunch of pages. Think about the snips like a page, and those snips are really important. They speak to major plot points, so major abilities of that gene to manage this. Okay. And so for this person here in this example, they have reduced capacity to actually activate that metabolism. And so they're not going to be receiving benefit from this. So the test goes so far as to counseling more what another dose might be, or looking at other agents, assuming there's no other contraindications with those agents. Again, audience, this is not something that you need to be understanding. This is something that you can bring forward to your provider, either through the report or through the app. But again, it's really important. I've just listed off two very common medications, codeine for instances of trauma or post surgery, and then this antithrombotic agent that is prescribed as part of an anti or a post heart attack regime. Audience, unfortunately, many people, either yourself or your loved ones, are going to encounter these agents. And so, knowing your genetic predisposition to how you metabolize these guys is really important because it will shift not only their efficacy within your body, but that really grievous side effect profile. So I hope that answers some questions around PGX and how important it is. I think from a takeaway perspective, again, I think it's really important to get this testing and ensure that it's a live document. When you get it, send it to your GP, send it to any people who are prescribing medications for you, as well as get the app because the app can kind of be that thing that you carry around in your pocket. It's an electronic leash. We all keep them way too close to us all the time. But heaven forbid there be an emergent situation. You have that information close to you so that the doctor, the nurse, or whoever it is that is trying to support you has better information to support you. There's no doctor out there that wants to harm you. It's often just a miss of not having the information they need to support you better. So, audience, I am going to jump into the question and answers so that we can speak to whatever it is that you want to know. Just give me a second because I have to shift my screen around a little bit. Um, all right. Um, yeah. So Melinda is has said that they almost died due to a doctor's mistaken medication twice in 2 years. Oh, mon Dieu. I hope that's not third time's Melinda. That's just incredible to hear. And I'm sorry. I wish you were someone that defied the statistics, but as Tracy iterated through, unfortunately, those are part of the statistics. Um, they're saying that it's hard to advise or advocate for yourself in a life or death situation. How can you do this in any situation? So, Melinda, something that the DNA company is working on is an app that will be part of the ICE information. So, ICE stands for in case of emergency. And this is information, it will have emergency contacts. Sometimes it will put in, you can enter in yourself if you have anaphylactic allergies or if you know you're already allergic to certain medications. But what we're working to do through this app is that when you call up this, and paramedics can call up this, right? I'm most familiar with the Apple system, but Apple has a way, and they train paramedics in this, that they can open a person's phone to get this ICE information pre-populated. And so we're working to figure out a way to bring in this medication, this PGX information, so that when a paramedic or a doctor or a nurse or whoever that emergent responder is, when they're responding to you, they can pull up this information. They know your emergency contact, your allergies, any medical conditions, as well as from a genetic perspective, what drugs do and do not jive well with you. So, Melinda, that's in the works. So please stay attuned to the environment. But if you do get the DNA Way app, you'll see updates there, especially when we're able to integrate into that ICE system. All right. Um, the name of so Simona is asking the question, the application, this will be all available through the DNA Way app, and Katie or Vanny will be able to put a link so that you can download that. Okay. Uh, Okay, so Pamela is asking a question. In 2018, I had a DNA test ordered by my psychiatrist because so many prescriptions weren't working. And unfortunately, Pamela, again, very common. Has this technology for these tests changed a lot? Um, Yes. So I wouldn't say it's the technology insofar as testing for genes. That has remained pretty consistent since 2018. We've advanced, but more what has changed since 2018 is the access to information that we have. So PGX reports the information, the awareness we have of drug gene interactions comes from several different places. It's becoming more and more incorporated into clinical studies, meaning as part of the clinical trial that says this medication is effective for these things and it's not going to harm people, is a study of genes. Additional to that, and this is especially for older medications, we have such a robust reporting library of adverse effects, a lot of computer geeks, data geeks have gone in and mapped out genes that align to those effects. So some of it is data, some of it is reporting. So has the test, the technology, the gene technology changed? No, your genes are your genes. What has changed is the volume of information available is exponentially growing. So people ask the question, does this test ever expire? For older drugs, no, because we have a pretty well established pharmacogenomic perspective of them. What will change in time and is going to be new drugs as we add them in or as we get more information. So I would offer right now, my counsel is about every 5 years to be redoing this test. Not because your genes have changed, but because the information has changed. But through the app, you'll have access to those genes as well. So you can MacGyver it if you want, but it's something I'd recommend about every 5 years. And yes, the information has changed a lot. Susan is asking a question of, does this tell if BHRT is a good fit? So audience BHRT stands for bioidentical hormone or replacement therapy. And no, Susan, so this does not go into that. Instead, what I'd look or what I would recommend for that would be our DNA 360, which looks at different hormone profiles, as well as risk of estrogen toxicity, as well as monitoring through either a Mira test or a Dutch. You'd want to work with your provider to figure out that monitoring, but you'd be looking at a different set of genes, more pathway genes, as opposed to the biologic prescription. Nancy's asked the question of what genes determine if you're a slow or fast metabolizer. So, Nancy, it's always going to be specific to the drug. Often, a lot of drugs are designed against a lot of the CYP family, which is a big family of enzymes within the liver, but every drug will rely on different enzymes. So it's an element of getting the test to understand by drug what enzymes are part of that reaction, as well as different SNPs. So that last example of the anticoagulant that I discussed, right? There's two SNPs within the same gene or two pages within the same book. So it's very much a matter of looking at the test, and then you'll see in context of different drugs if you're slow or fast. Okay. I hope that's helpful, Nancy. Faye is asking the question of, actually, a similar question to what Nancy just asked. So, Faye, I hope that answered your question as well. Um, Marianne is asking the question of, do all PGX tests from different companies test for the same drugs? Different companies will have different slants on it. So, for example, some companies will focus exclusively on psychiatric drugs. So, if you're being prescribed a mood drug, here's a panel that looks exclusively at that, or here's a panel that looks exclusively at cardiovascular agents. Different companies will also have different thresholds of evidence. So if you remember in one of the last questions, I talked about how we get information, especially with new drugs, there's always new information coming in. And so different companies will have different thresholds as to when they start presenting it. One thing I like, a strength about our PGX testing is it's very clear about the evidence level. So it will say this is well established evidence, this is emerging evidence, or this is theoretical evidence. And so I think being able to read that into a report becomes really important. And so I'm biased. I like RPGX tests, but yes, some companies will focus just on a specific area and other companies will have different evidence levels. So make sure you're considering those two things when you're deciding a purchase. And feel free to reach out if you want to see a sample report from us so you can kind of see that enlivened for yourself or for a family member. All right. Tony is asking the question. Um, how detailed is the report in terms of choosing a correct med, for example, for ADHD or bipolar in kids? Um, they're saying that this would be amazing to skip over the trial and error. Yeah. So, Tony, I would offer if you have very specific drugs that you're hoping to understand, feel free to shoot us an email. You'd want to reach out to CEO at thednacompany.com. We can confirm that those different agents are on there, but I would offer that for both those categories, so for mood altering drugs as well as stimulants, the report will list out several and it will speak to aptitude or ability to receive those. And for drugs that aren't a good fit, oftentimes it'll suggest a different agent as well. So those categories, because there's a lot of drugs within them, a lot of drugs are considered within the test. And so you'll be able to see um, it's quite literally set up as a red, yellow, green light system. So green meaning there's no genetic interactions, yellow meaning there's some you might want to be cautious, red being don't do this unless there's no other choice and here's how you can mitigate some of the trouble. And so you can really look within each of those categories where different agents are so that you can pick something hopefully within the green category for this. So Tony, I hope that answered your question. So Melinda's asking the question of, I already took a DNA test. Do you need a new one for drug interactions? Melinda, I'm going to imagine the DNA test you took is our DNA 360. If so, yes, you would need a separate and new test. Within the DNA 360, we test for functional genes. So, genes that influence the functioning and physiology of the body and can help us understand how we best uh, offer health advice. This is a different panel and it goes through in the laboratory a different sequence. So, we would need a new sample. It's just a cheek swab. And again, we have that discount code. So, Tracy has again, because we're so passionate about this, we have dropped the cost of this test by about $200, as well as for those that are on the webinar tonight, for your friends, for your family, anyone that's seeking to order, we're offering an additional 15% off, 15% off, with the code of Save a Life. That's Save with a capital S, A with a capital A, and a life with a capital L, and that is a life as in Fred, not life as in Victor. Okay. Um, the next question we have is again from Melinda. Drugs change all the time. New ones are developed. How will they keep us up to date on those drugs as it relates to DNA? Yeah. So, until we get to a point where we have a test that kind of rolls in all this information, there's always new genes that are newly associated with this. So, unfortunately, it does require, at present at least, I would say testing every 5 years. If you have a complex health history or you're on a lot of medications, you may even want to consider testing in a smaller window, because right now a lot of it is there's new genes added, there's a few other things that are going on that need to be considered. So it does have to be retested every once in a while, not because your genes are changing, but because this information is beautifully evolving and growing so quickly. So I hope that answered your question there, Melinda. Um, Linda is asking, is Medicare currently paying for this test? As I understand it through certain insurance providers, yes, it is. If you want more detailed information on that, specifically, is this something relevant to you? Feel free to reach out to a CEO at thednacompany.com and we can facilitate that more nuanced understanding if your insurance provider is qualified within that. So I hope that answers your question there. Um, so Michelle is asking a question. How does the DNA company test compare to other DNA tests we can do in regards to functional genes tested, medications included, and accuracy? So Michelle, just to ensure I'm being very clear and specific, our functional test is our DNA 360. And that covers genes that is it's 360 is a happy name. It's a full encompassing test. It looks at mood behavior genes, medication or sorry, cardiovascular, hormone, sleep, appetite, diet, nutrition, things of those nature. It looks at those genes and says, based on these genes, here's how your body functions. Here's how your body might present in the world. You have a gene profile that predisposes towards risk of diabetes, for example. You have a gene profile that makes you more mental or emotionally sensitive, something like that. So that one does not touch on any of any of the medications. It's the PGX specifically, or pharmacogenomics testing. That is what we've discussed tonight, that is able to peer into your genes and say, based on your genes, here are medications that you do or do not do well with. So there are two separate tests. That means also two separate swabs. I just want to be very clear and specific about that. Um, as regards to how we compare to the market, um, I'm biased, but I would also offer I work as chief of science. I work really, really, really hard to make sure we're top of market, in particular in from a functional space, ensuring that any gene we speak to has a true so what? So what? Meaning, if I tell you a gene, if my gene is different than your gene, so what? Does that change us as people? And in my mind, that answer always has to be yes, or else why are we looking at this gene, right? We need to see evidence and impact from the gene. So I would offer we're very competitive, if not top of the game. I think we rank amongst top providers out there. And I really do like our PGX. I think it's very well organized, it's accessible. And I think once we have that app plugin where you're able to bring up that ICE information, we'll be ahead of it all. It's really important stuff that we're doing. So again, biased, but I love what we're doing. Um, Michelle is asking the question of, yeah, so Michelle's also asking a question of coverage by insurance. Again, Michelle, please reach out to us, CEO at thednacompany.com, and we can support that understanding. Um, and Michelle's also asking around the discount. Yeah, I feel so again, yes, save a life, all capitalized. That will get you a 15% off discount. And we've already discounted the test by $200 to anyone, again, because it's really important to us and we know how important and vital this information is. Uh, and Faye's asking the last question here, is the PGX taste test based on saliva? No, it was once upon a time, Michelle or Faye, sorry. But we've switched to a buccal swab. This means you get a little, it's a fancy Q-tip, but you get a fancy little cotton swab. You stick it in your cheek and you rub it around for a little while. It's going to pull off endothelia or cheek cells effectively. And that's where the DNA is extracted from. We switched to this in part because we wanted to support younger as well as older populations who might have a bit of difficulty producing that much saliva. We also did it for populations where instructions might be a little bit more difficult to offer them. We did that to the end of accessibility. And interestingly, also for the nerds out there, it's actually gotten us better at the lab. There's less contamination of samples. So it's turned out as well from a lab perspective to be a lot more successful for us as well. So just a little cheek swab, you send it off, and then you get your results about 4 to 6 weeks later. Yeah. So, audience, I know this was a very different webinar relative to ones that we've been doing. We kind of had Tracy in all her glory and passion come in and talk about how important this project is to the DNA company, right? Our mission that we're very plain about is save one more life. We want to save one more life. And so, very much inspired and in honor of the memory of Tracy's sister, we've brought this in because it is powerful, because unfortunately, people do die from very avoidable mistakes. And that's not because a doctor wanted someone to die, that's because they didn't have that information or they didn't think to get that information and incorporate that information. So, again, I really, really, really hope that you go out and you get this test. I hope that you share this test with your friends and family because, again, based on simply the statistics that we're talking about, and for a history that we can't really control, doctors haven't really brought this into their day to day practices. And so this has to be something that you, as a patient, is advocating for. And so please do advocate for yourself. Get this test, share it with your providers, share it with your GP, share it with anyone that is prescribing medications so that when they're considering an agent, they can look up, is there any known interaction? And more importantly, is it actually going to work? Anyone who's taken kind of mood altering drugs can tell you how many times it took them before they found that appropriate agent. Or so many people can also talk to, they went to their doctor to lower blood pressure and they started layering on multiple medications before they got to an end. PGX is something that can cut a lot of that down because it really peers into, is this drug going to work in your system? Are we going to get the impact that we're hoping for? Yeah. All right, audience, I don't see any other questions. So I believe I'm going to hold off just a few more seconds to see if anyone has any questions. But after that, I'm going to let you go. Class is out a little bit early this evening. But again, I do encourage you to reach out to us if you have any questions. We can support with that understanding of, is this covered by your insurance? Um, and again, please reach out to us if you do have any questions. We want to make sure that we're out there supporting, saving one more life. And this PGX testing, pharmacogenomics testing, is a huge enabler of that. All right, audience, I see no more questions. So I believe that is where I bid you all adieu. Thank you so much for joining us this evening. I hope the session was informative, and I really do encourage you to talk amongst yourselves, to talk with family so that you can start better advocating for yourself. Until next time, I'm going to dance out of here because dancing is shown to be the best exercise to support happiness. And in today's crazy times, we know we need some more happiness. So, Vanny or Katie, if you want to cue the music, I'm going to dance out with the audience. Ready? All right, there we go. Au revoir, mes amis. Au revoir. Dancing is medicine. I love it, Faye.